Okay. Hi, everyone. Welcome to today's webinar. I'm Tom Bliss. I'm the project manager here at Center for Healthy Sex. And we're happy to welcome today Vena Blanchard, surrogate therapist. And before we get started, I just want to let you know if you're joining us online, you can always type in questions in the chat window to the left of your screen. And if you're joining us by phone, you can always email me questions at tom@centerforhealthysex.com, and I'll type them in the chat window for you. Center for Healthy Sex is a therapy center here in Los Angeles. We specialize in sex addiction, love addiction, and sex therapy. And we also offer several intensives. Feel free to check us out at centerforhealthysex.com. And I want to draw your attention as it comes up to the holiday season to the book that Alexandra and I co-wrote, Mirror of Intimacy. And for Black Friday, we're going to offer a 3-day sale, 40% off, so you can check that out on Amazon. So I'm really happy today to introduce you and reintroduce you to people that are familiar with Vena's work. Vena Blanchard, who is the leading authority on surrogate therapy. Vena completed her doctorate in human sexuality at the Institute for the Advanced Study of Human Sexuality in 2006. She's a professional member of the American Association of Sex Educators, Counselors, and Therapists, ASECT, and also the Society for the Scientific Study of Sexuality, QuadX, I think it's called. Certified in both sex education and clinical sexology. Vena is currently on the board of directors of QuadX and president of the International Professional Surrogates Association, IPSA, as well as IPSA's senior trainer. She teaches undergrads and graduate students about human sexuality and sex therapy at universities and colleges throughout Southern California, and some of the places she taught at include UCLA, UCSD, San Diego State, University of Phoenix, and many more. She has a private counseling practice in Los Angeles, and for over 3 decades there, she has enjoyed helping adults overcome difficulties with physical and emotional intimacy. You can visit her website at venablanchard.com. Vena, welcome.
Thank you, Tom, and welcome to everyone who's tuned in for the webinar or who will be looking at it online at a later time or listening to it in a different way. I've put a lot of information on the PowerPoint slides, so if you're not actually looking at those, you might want to check out YouTube and the places that the PowerPoint slides will be visible at another time. The focus of this talk is really basic understanding about surrogate partner therapy, what it is, a little bit about what it isn't, and whether or not it might be valuable for you or your clients. And the point of view that I'm going to share is really about the intimacy-focused surrogate partner therapy. There are some people around the world who claim to do something like surrogate therapy, but it's different than what I'm going to describe. Sometimes it's just providing sexual services and co-opting the name, and sometimes it's an attempt to provide genuine health and healing, but slightly different than this model. This model is the model from this International Professional Surrogates Association, which, as Tom said, I'm the president and senior trainer for that organization. So a little bit about the history and science of surrogate partner therapy. It really the concept originated with William Masters and Virginia Johnson. They did research in the 1960s talking about or looking at what happened physiologically inside the human body when it was working its way through the sexual response cycle. They identified arousal and plateau and orgasm and a resolution phase. But they also identified that there were some people who either didn't make it through those phases or weren't satisfied with the experience that they had as they were trying to engage sexually. And as a result of their initial research, they concluded that people who were more satisfied with their sexuality were experiencing something slightly different than people who were unsatisfied, not just in how they made it through the physiological cycle, and not just whether or not they reported satisfaction, but what they were experiencing in the middle of the process, where they were paying attention, what they were ignoring, and where they were, what their body was experiencing. And it occurred to them that it might be possible to help teach the people who weren't satisfied with their sexuality to think about sex and focus on sexuality in a different way, more like the people who were experiencing satisfaction. And so they did about 11 years of research trying to see if they could help people become more satisfied and more functional in terms of getting through that sexual arousal cycle. And they discovered that, lo and behold, you can, in fact, teach people to pay attention differently, and paying attention differently changed their sense of satisfaction and how they made it through that cycle. So the major differences were that people who were having trouble were overly focused on performance and the mechanics of sexuality, and people who were satisfied were focused on pleasure in the body and in the emotional connection that they had with their partners. And that you could give people this information, educate them a little bit about the sexual body and reproduction, and work on their sort of ongoing relationship issues, resentments that had built up, or poor communication skills, but that you also really had to focus on what they were thinking about, where they put their attention. And they called this process the sensate focus process. To focus on sensation was what they considered most important. And then to also focus on the relationship and the connection with the partner. They gave directed behavioral assignments to couples, and by encouraging them to focus on the sensation in touch rather than on intercourse and orgasms and performance and how their partner might judge them, and also getting them to pay attention to the emotional connection that they had with their partners, it shifted the experience of the couples they were treating. Their point of view was that no sexual dysfunction exists for an individual, that it happens in relationship, and that the treatment was best performed in relationship, dealing with relationship issues, but also in partnered exercises. And they coined the term or the phrase that the relationship is the vehicle for change. That required having a cooperative partner to work with the client who was having difficulty. Usually, so the research was done in the late 50s and all through the 60s. And they worked with married couples primarily. And so it was usually a spouse. They worked with female sexual dysfunction and male sexual dysfunction. And then they tried to figure out what to do with single people who didn't have a cooperative partner, no friend who was willing to go through a 2-week intensive therapy program in St. Louis, which is where they conducted their treatment. And it occurred to them that perhaps what they could do for single people, since their treatment program was so effective for couples, was to provide a partner surrogate or a spouse surrogate to go through the program with the person who was having sexual disorder. And because they were scientists and they were planning to publish this, they looked at the effectiveness of their treatment program for couples, which they found to be at about 80% success for people who went through their program. Regardless of the sexual dysfunction, it was approximately 80%. And that the people who went through with the partner surrogates were equally or more effective, or the treatment was equally or more effective with a partner surrogate as it was with a spouse. This is really important to understand. They were using the same treatment methodology. They were using the same concepts. They were simply substituting the permanent or committed partner and using a trained person who would form a brand new relationship with the client. There are other people who have done research into the concept of surrogate partner therapy right around the same time that Masters and Johnson were doing their research. Martin Cole was doing similar research in the United Kingdom, and people here in California, Bernie Applebaum, Bernie Zilbergeld, Barbara Roberts, all clinicians who were working with clients using what they had learned from Masters and Johnson, and but expanding on the concept of surrogate partner therapy, finding that it was also successful. Masters and Johnson had, or actually Bill Masters primarily, had a point of view that while male clients would be able to successfully partner with a female surrogate partner, that that it wasn't, he believed, possible for a female client to form enough of a connection with a male surrogate partner in just 2 weeks in order to be effective. And so they didn't train male surrogate partners. However, the California therapists immediately began training male surrogate partners. They didn't have the same prejudice or point of view that Bill Masters had, and they found that male surrogate partners were as effective in working with female clients. Then sort of more recently, in about 2007, 2009, there was some research done in Israel by an author by the last name Ben Zion and his colleague Ronit Alani and some of their other colleagues, working with female clients partnered with male surrogate partners and comparing their treatment inside the clinic with their treatment of married couples or partnered committed couples. They were working in this case on the specific female sexual dysfunction of vaginismus, which is the anxiety disorder where there's a spastic contraction of the vaginal muscles that makes penetration very painful, sometimes impossible. And what they found was that the female clients working with male surrogate partners had better treatment outcomes than women working with spouses. The couples often dropped out of therapy, often leading to divorce or separation, whereas every single one of the female surrogate partners working with a male surrogate partner went entirely through the process and had success in that program. It's important then to keep in mind that surrogate partner therapy is an extension of traditional sex therapy, and the common components of all sex therapy treatment are that there's a talk therapy part of the treatment and there's an experiential learning part of the treatment. Talk therapy is your traditional psychotherapy, working on deep psychological issues left over from childhood, traumatic experiences, and or lack of education about sexuality, poor modeling from parents and the culture at large, working on couples counseling, the issues between spouses and or partners, and dealing with the sort of what therapists might call cognitive distortions and wrong thinking about relationships and sexuality. And as the experiential learning part of sex therapy is teaching basic concepts of relaxation, good communication skills, mindful awareness of the body that we call sensate focus. This desensitization, meaning if there's a thing you feel very anxious about, we can help you get more comfortable about that thing in the same way that you help people overcome fears of flying or driving or elevators or snakes or any of the other things people might be frightened about. You work in a very gradual way to help them get more and more comfortable with something that's close to but not exactly like the thing they're afraid of. And there are people who have sexual disorders that are really phobia and anxiety based. And so there's a desensitization process to reduce the amount of anxiety triggered by these experiences, whether it's nudity or expressing your feelings or asking someone out. And this desensitization is paired with a behavioral therapy concept of successive approximation. Those are basically the same ideas. You get closer to this thing you ultimately want, but you do it in such little steps that it doesn't raise the anxiety too high, and the person begins to shift their expectation and anticipations from negative anticipation and anticipatory anxiety to an anticipation of relaxation and comfort and connection. And another important part of this experiential learning that happens in sex therapy is that people are given these concrete homework exercises to do with their partners at home. Additionally, clients who might have a medical cause for their sexual disorders or their relationship difficulties, whether it's psychiatric or physiologic, will be sent for an evaluation from a medical team. So these common features of most sex therapy, which includes surrogate partner therapy, combine in the surrogate partner therapy. It's not different from sex therapy in most ways. And so all the research that tells us that sex therapy is effective, in fact, highly effective, also tells us that using those same methods, surrogate partner therapy is likely to be highly effective, since both the Israeli research and the research here in the US by Masters and Johnson confirm, like almost 40 years apart, that surrogate partner therapy is as effective as couples treatment when using the same methods. So they said the relationship is the vehicle for change. But what if the client doesn't have a relationship? And that's where they came up with the idea of a trained surrogate partner. So you have here the client with the green face who seeks treatment with a therapist, and the therapist then refers that client at some point to a surrogate partner. And they then become a therapeutic triad, a team working together to resolve the client's difficulties. The client brings not only the problem, but all their self-awareness, their insight, their response to the treatment program. The therapist brings all their psychotherapy training. And if they're working with a private partner, then they're bringing the partner's commitments, but also sometimes the partner's complaints and personal needs and their own difficulties. When they're working with a surrogate partner, the surrogate partner leaves a lot of their personal challenges at home and is, in this sense, an emotionally committed, cooperative partner. But there isn't an existing relationship between surrogate and client. And so the initial stages of the work are designed to help establish a relationship. The client first establishes a relationship with their therapist. The therapist assesses the client's problems and helps decide what's in the client's best interest, whether a $14.95 paperback is going to help solve their problem, or deep psychotherapy for 14 years is necessary, or at some point, whether those things are not working, perhaps working with a surrogate partner might be more useful way to address the client's difficulties. If the therapist believes that, they might then contact the surrogate partner and discuss the case, and the surrogate will also weigh in about whether or not this seems like an appropriate client for surrogate partner therapy. The triad initially meets in the therapist's office. That's a place the client is comfortable and familiar. The therapist then gets to observe the interaction between the surrogate and the client, and this is an information gathering session. They're having a conversation about the client's concerns, about their goals for therapy. The surrogate is explaining surrogate partner therapy, who she or he is and how they work, and the client and surrogate are making a decision about whether or not to move forward with the therapy. If the client moves forward, then they will typically see the surrogate partner in the surrogate's workspace and continue to see the therapist for regular sessions, and then the therapist and the surrogate partner will talk on the phone or exchange emails or meet in person, so that it becomes this triadic relationship, but the meetings are usually in dyads, each two members having their own interaction and then reporting to the third person about what they experienced. Surrogate partner typically talks with the therapist after every session the surrogate has with the client, and those conversations are both reporting what happened and making plans for how best to address the client's issues and their reactions to the treatment process. The therapist also meets with the client to get a report about the client's experience and reports back to the surrogate partner what the client is experiencing, not to do the work for the client of developing the relationship, but rather to confirm that the surrogate's perceptions of the client are accurate and that the therapist is still in agreement about how to structure the next session. So this is an open, honest communication between therapist, surrogate partner, and client. Very important that it be consistent, open communication and regular contact. The surrogate and client work together through a course of treatment. I'm going to talk about the arc of that treatment in a minute. But at some point, then they make a decision that the work between the surrogate and the client has met the goals, the revised goals, and the client is ready to move on from that relationship. Usually the client continues with their therapist, the therapist helping them process the closure of this relationship and helping them to generalize what they learned into the next relationship. There are some unique features of surrogate partner therapy that are worth noting, and these are often the things that give people concern or raise questions, create myths about surrogate partner therapy. And they mostly center around the fact that the relationship between the surrogate and the client becomes the crucible for change. It becomes the vehicle in which client can practice new skills, develop new understandings, learn to be different in the interaction. It is what they are often doing, what a couple would do at home in their homework part of the sex therapy treatment. This clinical relationship then is a crucible. It is the place that stimulates change, both because of the exercises and because of the human connection between the surrogate and the client. There's an emphasis on emotional connection, helping the client to be able to connect with a partner, not a pretend connection, a real connection, real human beings getting to know each other, real human beings experiencing enjoyment, but also frustrations and working through conflict, working on helping the client to breathe and relax during the experience of anxiety, practicing relaxation together, but also talking about how it feels to be doing this process together and to be real about the real feelings that are emerging, whatever they might be. And there's touch between the surrogate and the client. That touch is initially non-sexual, it's nurturing, but because there is an emphasis on the experiential learning, and the learning is in the area of physical and emotional intimacy, then there is the need to engage in some degree of physical intimacy to help identify the client's difficulties and help them develop new skills so they move beyond those difficulties. And it's these areas, the emotional intimacy and the physical intimacy, that tend to stir up people's anxieties about surrogate partner therapy. The concern about if there are real feelings, will somebody's feelings get hurt is common. Or if you are outside the traditional boundaries of psychotherapy, are there any boundaries? There are boundaries. They're important for the client's health and well-being and for making the process beneficial to the client. Another area of interest and uniqueness is that there's nudity often in the surrogate and client sessions. And additionally, there not only is eroticism or the potential for it, but there's a focus or attention to the potential for eroticism and the lacking of eroticism. But by eroticism, I don't just mean sex behaviors. I mean the feelings of joy, attachment, connection, enthusiasm, pleasure, and focus on pleasure instead of performance, a focus on arousal. Where is arousal? What sparks arousal? What inhibits arousal? This is a chance to learn experientially about those things and then resolve them so that the client can carry forward into their future healthy relationships the capacity for emotional connection and physical connection and eroticism. Some clients have difficulties way before the erotic arena. They don't know how to ask someone for a date or talk in public. They have social anxiety, and surrogate partner therapy might also address those social skills issues and social anxiety issues. And then finally, there is a planned closure. There will be a conclusion to the treatment, and that's going to be a very conscious, deliberate part of the relationship, an acknowledged part of the relationship. There's closure in every relationship. People die, we change, there's divorce, but we rarely make it a conscious part of the relationship from beginning to end. There are standard ways in which surrogate partner therapy is practiced. The therapist and surrogate generally have collaborative private practices, meaning they each have a separate office. They see the client in separate places, but they consult with each other in between sessions. Typically, that's once a week, although it might be that for a variety of reasons, the therapist and client and surrogate agree that working more intensively might be useful. If the client lives in the middle of the US, there often is not surrogate partner therapy available to them, no surrogate partners in their state, much less their city. And so they might travel to another part of the world to work with a therapist and surrogate team. And usually people need to take time off work, and so you often see the therapist and the surrogate every single day for a period of a week to 2 weeks, and sometimes to return for additional intensive therapy sessions. It's also true that sometimes people, while they have a surrogate in their state, they don't have anyone in their town, and they have to drive so far that they'd rather do longer sessions and meet 2 days in a row. There are a few places, such as in Israel, where there are clinics and the client sees the surrogate partner in the clinic, that they also see the therapist just at different minutes. There are 4 primary functions of the surrogate-client relationship, and these are themes, threads that run throughout the therapy from beginning to end, regardless of whether it's weekly or intensive therapy. And that is that every session and every activity is simultaneously diagnostic, It provides an assessment of the client's skills and abilities, and also helps identify where their challenges are. And every single activity between the surrogate and client is also an opportunity for skill building, whether those are the emotional skills of knowing what you're feeling, or the communication skills of expressing those feelings, or the intersection of those two, whether it's the skill of focusing attention in the present rather than being worried about the past or the future, whether it's the skill of identifying anxiety and choosing to reduce the anxiety with breathing and relaxation and communication and connection. And simultaneously, this is also a model for developing healthy relationships. The process, which we're going to be talking about, starts in such a gentle and safe way and is designed to build the relationship in conscious and sort of healthy ways, developing emotional intimacy and self-awareness, and the client being able to set boundaries, to express their needs, and to learn to be respectful of the other person, in this case, a surrogate partner. If they were working with their private partner, they would be working on these same relationship skills, but they might not be getting the sense that this is how you build a healthy relationship. So these things are pretty easy to describe. How doing an exercise and the client's report explains that, or helps us understand whether they're already good at communication or have difficulties, already good at being present or have difficulties, and how it might help build skills and how it might build a model for a healthy relationship. The part that's harder to make sense of for people who haven't been through the experience is that there is a transformational process that's taking place, the development of the person, of the client. And it happens as a result of this intimate relationship, this budding, honest, authentic relationship. And even though they're together for a reason, to help the client learn and grow, and it's time limited, during the interactions, it's two real people having this experience. You can't stop being a real person, and paying attention to that helps transform the experience into something that is more meaningful and deeper and more lasting for the client. So it's a common myth or misunderstanding that this is a mechanical process where a person is just put through a series of exercises. That's completely not what's happening. The client is participating in decision making. The client is reporting their experience, and the surrogate is also reporting, because how the surrogate partner experiences the client gives us information about how people experience the client, and it's helpful for the therapist and surrogate to talk to each other about how they're experiencing this particular client. So I said there's an arc to the relationship, and it's important to understand that the relationship with a surrogate partner starts at what we might think of as the most basic developmental level, at building trust and providing nurturing and developing the most basic skills. And this trust and nurturing and basic skills provides this really broad, solid, healthy foundation for then developing the rest of the relationship. Clients enter therapy with hope and faith, but trust is born of knowledge and the repeated experience of another person. Knowing who they are tells us what we can trust them to be. And so the surrogate and client need time to develop a relationship, to know each other in order to have genuine trust in each other. The initial touching exercises are all about building basic skills, like the client is touching an object and feeling the texture and temperature, sensing it, tuning into the experience in his or her own body. And that's the beginning of developing this mindful awareness of sensation, or the focus on sensation. The initial touching between surrogate and client is divided into one active partner and one passive partner. And that allows us to discover whether the client has difficulty receiving or in being the creator of their own experience. But the arena of this is done in non-sexual, non-threatening kinds of touch. So it might be hand on hand if the client can tolerate that level of intimacy. If they can't, it might be something like, as I said, it would begin with objects, but it might move on to something like touching of hands, and eventually something much more intimate, challenging for some people, easy for others, the touching of face or the touching of feet. Notice these are not traditionally sexual. If a client experienced these as a highly charged sexual body part, then they wouldn't be included in the early stages, because we're creating an environment of warmth and safety and familiarity and trust, much as we do for our infants and small children, to hold and nurture them. And from that place of safety, then they eventually grow to be able to be the creators of their own world. The second stage of the treatment is now more about whole body acceptance and sensuality and a deepening level of emotional intimacy. And while my slide here says that it's about sensuality and intimacy, I've taken to thinking about it much more as the stage of whole person and whole body acceptance. And at this, the transition between stage 1 and stage 2 is that we're also possibly including nudity or partial nudity. So it might be a caress of the back or the back of the body without a shirt, and addressing body image issues that are inhibiting for the client, and addressing whatever emotional issues come up with this increased level of intimacy. Remember, the client is always going back and processing each session with their therapist, talking about what emotional material came up, what was confusing, what made sense, what they enjoyed, how they're feeling about the surrogate partner, as well as talking about, their feelings about their parents and their childhood and their boss and the rest of their life. Stage 3 is where we then begin to address mutuality and eroticism. And up until now, all the touching has been divided into one passive and one active partner. And now it's the clients learning about how to be active at the same time that their partner is active, and to still maintain relaxation and trust and comfort. When you think about a client who may have been traumatized in the past, this level of intimacy would be terrifying if we hadn't built the first couple of stages of trust and sensuality that had nothing to do with sexuality and eroticism. And then in this third stage is where we can address specific sexual dysfunctions directly if they exist. And the fourth stage is where we work on the conscious closure and help celebrate all the growth and learning, but also turn the client towards the future and how they're going to apply what they've learned in the next stage of their life. I want to talk for a moment about the role of the supervising therapist. As I said, the therapist needs to assess the client's appropriateness for this form of therapy. Are they ready? And even before that, is this even a kind of therapy that they need? The therapist also is evaluating the surrogate partner and deciding who's the appropriate person for the client to work with. Clients, of course, have a right to decline to work with a surrogate partner for some reason, but the therapist is the one that does the initial search for the surrogate partner and the initial screening. The therapist also has a job to maintain an objective overview, talking to both the surrogate and the client, and helping to keep a sense of that the work is on track, and when there are problems, to help the surrogate and client resolve them. Inevitably, when people are engaging in change, there will be resistance and defensiveness, defending the way they used to be or their belief systems, and just naturally pushing away the discomfort of a change process. And it's the therapist's job to be able to talk to the client about that resistance and the feelings of reluctance to move forward, and what would the consequences be if they in fact changed the way they were to something that might provide them or meet the goals of their therapy, but be uncomfortable along the way. So the therapist actually has a job of helping to foster a strong, healthy relationship between the surrogate and client, and to help identify when there are problems in that relationship. Similarly, the surrogate partner is helping to pay attention to if the client's having trouble in his or her relationship with the therapist, and directing them back to talk with the therapist about the difficulty they're having, and use the relationship with the therapist as a vehicle for growth and change. And then ultimately, it's the therapist's job to help the client process the feelings that they have about ending the relationship with the surrogate, and helping them to shape their future without the surrogate. The kinds of clients who are appropriate for surrogate partner therapy are adults who don't have a partner to work with, who are experiencing a specific sexual dysfunction. For men, that might include rapid ejaculation, delayed orgasm, erection difficulties, pain with intercourse or sexuality, sexual fears and diversion, social phobias. They might have a lack of experience and feel shame about that. Truth is, female clients might have these social phobias and have delayed the beginning of their sex lives, and now feel out of sync with their peers and need some assistance. They might have this vaginismus, the contraction of vaginal muscles, or pain from a number of causes, whether it's fear or it's a physiologic cause. A common concern for women is the inability to have orgasms with partners. Some have never had orgasms at all. And many females and some men suffer from body dysmorphic disorder, this distorted idea about what they look like, but also sometimes a really honest assessment of how they look and recognition that it's outside the cultural norm in some way, whether it's from an injury or surgery or weight issues or skin tone. I had one client once who thought that he was an unacceptable male because he was so pale. He had pale white skin, and he thought that was a reason to not partner, and wanting to overcome that feeling was his main reason for being in therapy. Some people have adjustment issues to a recently acquired disability or medical condition. It's quite common, and I would say the majority of clients coming for maybe 50% of clients seeking surrogate partner therapy fall into that midlife virgin category. But the other large categories have to do with being abused and traumatized in childhood or afterwards. So victims of rape, child molestation, or profound neglect by parents, and lack of experience building trust or having trust with caregivers of any kind. Sometimes people have a discomfort with their own sexual orientation or gender, and there's some benefits to working with a surrogate partner so they can explore something without engaging in a dishonest way with a partner in the world. People who aren't ready might be people who have profound mental illnesses or drug and alcohol addiction, and or are too newly in recovery because they aren't stable enough to tolerate the process. Selecting a surrogate partner, one of the best ways is to go to the International Professional Surrogates Association. They have a referrals network. You want to make sure that the surrogate is well trained, certified by IPSA, that they're intelligent and nurturing and compassionate, warm people, open to working on their own issues should those emerge. The IPSA website is listed here. I'm going to say it out loud for people who aren't seeing it. It's surrogatetherapy.org, or a short URL is also ipsa.us. So that's surrogatetherapy.org. They have a code of ethics and offer training and certification, and have a referrals coordinator who can help people find their way to therapists who work with surrogates, or surrogates who are available in their community if it's a therapist. One of the major questions about surrogate partner therapy is this legal? And that usually arises out of because it's a really unique treatment form that does have touch and nudity and emotions that are not typical in psychotherapy. As far as we know, there are no laws prohibiting surrogate partner therapy or the referral to surrogates. And neither are there licensing boards that restrict therapists being involved in surrogate partner therapy. We know for sure in California, the licensing boards are well aware of surrogate partner therapy, as are district attorneys. Our current California Attorney General was on record when she was a district attorney in the Bay Area saying that surrogate partner therapy was not illegal. I think the other ethical question that needs to be asked is, what is in the client's best interest? Do they in fact need this treatment? And if they do, is it ethical even to withhold it from them? And is there another treatment method that might be equally beneficial? Not every client is comfortable working with a surrogate partner. It can be expensive to pay the therapist's fee and the surrogate partner's fees. And some clients will save for a couple of years to be able to do this treatment program. Surrogates' fees tend to be very similar to therapists' fees in a given community. And in California, I think the average is about $150 an hour. There are some unique challenges for therapists who are working with surrogate partners and supervising this. And one of it's just that it's an unfamiliar area where they don't have previous training and skill. There's a YouTube video of me giving a lecture at the American Association of Sex Educators, Counselors, and Therapists conference a couple of years ago, and it's designed specifically for supervising therapists. I think you can get to it off the IPSA website. I should be able to say that it's on my website, but I actually think it isn't. You might be able to get to it just by Googling it. I haven't tried that. But if you write to me, if you weren't able to find it, I'm happy to send you to that video, which is an hour-long presentation really aimed at therapists for how to think about supervising surrogate partner therapy. We have to refer our clients out for all kinds of treatment we can't provide, whether it's specific religious counseling or medical evaluation. And sometimes it's to refer to a surrogate partner for the experiential learning they cannot get in the psychotherapy process. And if a therapist knows that this is a good treatment for the client, but they aren't comfortable participating, then it might be that the most ethical referral is actually to refer the client to a different therapist who is willing to supervise the surrogate partner therapy. I'm going to skip this, but just to say that there are a lot of therapy there are a lot of theoretical models that are sort of the foundation for surrogate partner therapy, and that the structure of the sessions is very similar to what you would expect in any human interaction: a conversation, some activity, and some conversation. Those conversations are also skill building and diagnostic and a model for relationship. The experiential learning is more designed to be skill building and this gradual exposure to things that are anxiety provoking. And then the consultation with the therapist that the surrogate and client do is this processing of the experience that then leads into the next session. I talked about most of this on this slide, about the development of both physical, cognitive, and emotional skills, and some of that includes taking risks and exposing more of yourself. There are tremendous benefits that come from the sensate focus process. This is a slide about the process itself. The first couple of exercises are what I would call stage 1, the nurturing, trust-building stage. Back caress, front caress are more the whole body acceptance. And then the last exercises are really about this third stage of the work that's more about addressing specific problems with sexuality and eroticism. I want to read this little quote from me, because I thought I said it right. That for many clients, wounding in early relationships results in withdrawal from intimacy and sabotaging of future relationship opportunities. Defending against their fear of dependence, exposure, or loss, these clients deprive themselves of the maturational experiences and transformational influences of intimate, authentic relationships. Intimacy-focused surrogate partner therapy has the capacity to facilitate deep healing and self-actualization for such clients. So I'm happy to take questions if there are any. I haven't seen any pop up. I haven't given you a chance, but we have a little time left if anyone has questions. You will have access to the PowerPoint from me right to me at venablanchard.com, or give me, you can text me, although it's a little easier if you send email, because I'll be sending it through email to you. I don't know I believe this webinar remains available through the Center for Healthy Sex, and so the PowerPoint will be available that way.
Yes, the recording will be uploaded to youtube.com, Center for Healthy Sex. And I'm going to open up our phone line too, so people can talk. And let me just do that for one. It'll just take a second.
All attendees are muted and may unmute themselves by pressing *6.
Okay, so if you'd like to ask a question, just press *6. Thank you.
So someone, offered a thanks, and you're welcome. This was a fast run through of a pretty complicated process, and if you have additional questions, if you have specific clients that you think this might be useful for, or if you think it might be valuable for you, You can contact me directly. My phone number is 760-415-4220. You can text or leave a message there, and I'm happy to answer the question. And the International Professional Surrogates Association, you can contact through their website. There are a bunch of links to reach out to the referrals person, or you can just write to referrals@surrogatetherapy.org. Someone asks if there's a professional book on the subject. There really isn't. There are articles, but not an entire book on the subject. There have been a couple of anecdotal books written by surrogates, or a collection of commentary by surrogates. Women of the Light has an article by Barbara Roberts, who was a therapist who was one of the founders of IPSA and trained a bunch of surrogates. And there's an article by her. The International Professional Surrogates Association on their website has a list, bibliography. I think on the nav bar up at the top, it says something like library or resources. And you check there, and there's a bibliography of virtually every professional article that's been written about surrogate partner therapy. And there are also, a bunch of popular articles that we've screened. Someone's asking if they can get listed as a certified sex therapist who works with a surrogate partner. And IPSA doesn't list therapists, but they do refer to surrogates. And if you have worked with surrogate partners, they do refer to therapists who work with surrogate partners. So if, Roger, if you've worked with surrogate partners, then you can join IPSA and get referrals through the IPSA referral network. And by the way, I just trained somebody up in your area, so call me and we'll talk about her. And somebody else is how this could be applied to forensic psychosexology, where we explore dysfunction that often leads to criminality. And I'm not sure how this could be applicable for forensic psychosexology, honestly. There have been some surrogate partners who have worked with clients who were registered sex offenders and or who were looking to develop their sexuality in new ways. And while we know that completely extinguishing a certain sexual interest is extremely difficult, it isn't difficult to develop additional interests and have alternative ways of expressing our sexuality. And that's the premise of all sex therapy, is that we can learn and grow and develop ourselves sexually and add to our sexuality and let go of bad habits or bad thinking or troublesome turn-ons in one way or another.
I have two questions. Is someone hearing me?
Yes. I can hear you.
Okay. One of them is, what about the sexually addicted client? Are there any additional considerations for a client who might be sexually addicted and highly arousing, ability to be highly aroused? And the other is, does the surrogate also utilize nudity? Is the surrogate sometimes fully nude? And like I noticed that breasts are not touched in the front touch, but it sounds like the front might be exposed. A female's breasts as a surrogate might be exposed. I'll stop before it gets more complicated.
Let me answer your second question first, because that's the quicker answer. Because it is a developing relationship, there's mutuality at every stage. So when they're touching hands, the surrogate is touching the client's hands, and then the client touches the surrogate's hands. And that's true at the stage of nudity and whole body touching as well, that the surrogate partner will, in some cases, disrobe with the client. It's tremendously powerful, by the way, for people with body image issues to see themselves standing in the mirror next to a real person who looks human, not a magazine image, but a real person who is naked with them and vulnerable with them. And I think it's one of the most powerful parts of surrogate partner therapy, that the surrogate is emotionally and physically vulnerable with the client, or developing that alongside the client. Actually, I think my experience has been that this is an extremely effective treatment method for people who self-identify or are diagnosed as having sex addiction, because we're developing these other skills, this emotional capacity for contact and connection and closeness. And I believe that that's an essential part of being able to move beyond this addictive, depersonalizing approach to sexuality. Of course, it might not be viewed in a positive way at certain stages of the treatment process. The therapist has to help evaluate when the client is ready to now develop the more sophisticated and mature kind of emotional connection, and build their eroticism based on that rather than on porn or dissociation. It's not designed specifically for people with sex addiction, but it's very applicable. And the process is necessarily slow with a lot of our clients. If they were able to move quickly through the treatment process, they would have done that and not needed surrogate partner therapy. So many of our clients are clients with greater difficulties that need the deeper, longer, slower treatment process. You're welcome. You're welcome. I see that we're approaching the end of the hour, and I appreciate this opportunity to chat with all of you. And I will take a look at the questions I didn't have a chance to get to. And if you want to text me your name, I will try and respond to you personally instead of in this hour. Again, I think it's the Center for Healthy Sex is doing the archiving. I was able to access some through YouTube, and I think it's possible that Tom will chime in again and say where people can access this.
Yes, hi. Thank you so much, Vena Blanchard, for your webinar today. And unfortunately, my screen, I'm looking at it frozen, so hopefully you're all hearing me. The talk will be archived on YouTube, and you can do just a basic search for Center for Healthy Sex on YouTube, or go directly to youtube.com/Center for Healthy Sex. Again, thank you so much, Vena. You can contact Vena for any questions or to get the handout at any time, the PowerPoint. And I'd like to all invite you to our next webinar, December 9th, with Paul Johannes. I was going to do this right. I'm going to have to ask him how he says his name. Johannes? Well, you can see this on our website, and he will be talking about he'll give a presentation based on his book, The Guide to Getting It On.
Which is a great book. Do
you know how to say his last name?
I don't. I guess. So I say it Joanides, but I don't really know how he pronounces it.
Okay, thanks, Vena. And again, thank you so much. All of you, thank you for joining us, and have a wonderful weekend.
Bye.